Hello.
Hello, sir.
Hello, everyone. Dr. Clark will be with us shortly.
Hi, Carissa. Good morning. Dr. Disha here.
Look looking. Warm in here this morning.
शिवानी भैया को कॉल कर दो अंकित भैया आ रहा हूँ मैं
Good morning. Good morning. Can you hear me?
Good morning, Dr. Clark. How are you?
Very well.
Nice to see you after so long.
Yes, it's good to see you too.
So, Dr. Clark, shall we start? And I'll give a little short introduction.
Okay, perfect.
I'll just share the screen. So, a very good morning to Dr. Clark and good evening to all my Indo-Valley friends. Today, the weather in Calcutta is again stormy and it started to rain. I really wish that our city heals soon. Today, it is an honor for me to introduce my mentor, my guru, Dr. David Clark, to all of you. Friends, Dr. David Clark is the inventor of the famous Bioclear matrices and the Bioclear concept for modern composite restorations. He is the founder of Bioclear Center in Tacoma, USA, and is the director of all Bioclear Learning Centers International. Dr. Clark founded the Academy of Microscope Enhanced Dentistry and is on the editorial board for several journals. He holds several US patents integral to Bioclear method and matrix system. Due to an ever-increasing demand from patients, Dr. Clark founded a dedicated Bioclear clinic in 2015. Its purpose was to cater to unique demands of patients traveling from United States and abroad for Bioclear method rejuvenation of their natural teeth. Since inventing the Bioclear method, Dr. Clark has restored thousands of teeth with compelling success, both in natural aesthetics of Bioclear, but more importantly, with improved health. Dr. Clark's interest includes redesigning of restorative and endodontic cavity preparations and overall of outdated GB black cavity shape. He has developed Bioclear matrix system that promises a real advancement for placement of biologically appropriate, aesthetically pleasing direct composite restorations for treating minimally invasive class 2 preparations, diastema closures, and black triangle elimination, combined with papilla regeneration, traditional anterior composites, and much more. Dr. Clark and Dr. John Kademi are acknowledged as fathers of modern of minimally invasive endodontics, which at first was rejected by the most American endodontists, but now now embraced by the mainstream. Dr. Clark published the first guide and classification system for dentine and enamel cracks based on 16x power magnification. He has written chapters for both aesthetic dentistry and endodontic textbooks. Dr. Clark has designed numerous instruments, burrs, wedges, matrices, separators, and equipment, and is still designing more and more. So dear colleagues, as my close friend Dr. Ashish says, be clear with Bioclear. Let us all hear and learn from the maestro himself, Dr. David Clark.
Wow, good morning. That's a very gracious introduction. Thank you, Disha, for putting that together. It's wonderful. You know, I'm listening to all those things that I've been doing. It just makes me tired. That's 30 years of nonstop work. So I'm very happy to be here this evening for all of you. Do we need to say hello to any of the people that are on your board of directors? Or do we get started? Maybe we could just, are these some of your directors? I can't hear you.
They all are my friends, Dr. Clark, and and they all are interested in Bioclear techniques, and most of them are most renowned dentists of India who are doing microscope dentistry.
Can we just hear hello from some of your these folks here? They can just say hello and what city that they're in and what kind of dentistry they like to do, just very quickly. Is that okay? Oh, the lights.
Yeah,
okay.
Sure, guys. Please go ahead.
I am Dr. Anuj, and I've been lucky to learn Bioclear from Disha. She's a wonderful mentor with Bioclear, and I am hoping to learn more from you today. And I stay in the central part of India, that's Indore, and I've been doing magnification dentistry for the last 9 years, a private practice. Nice to see you, Clark.
Hello, Dr. Clark. I'm Dr. Rohit Khatawkar from Mumbai, and I'm an endodontist and a consultant of Disha. And I've had the opportunity to meet you and attend a lecture delivered by you in Mumbai at FAMDent. So it's great to see you back and learn more from you.
Hi, Dr. Clark. This is Dr. Laura Mishra. I'm professor in Faculty of Dental Sciences in the eastern part of India, Bhubaneswar. And I got to know about Bioclear because of Disha. Disha and I are alumni of one of the colleges in India called Savita Dental College, Chennai. And she's so passionate about Bioclear that she has rubbed her passion on us as well. So thank you, Disha, and thank you, sir, so much for getting to have conversation directly with you. So thank you so much. Looking forward for your presentation.
Great.
Anyone else wants to join in for the introduction? Yes, ma'am. Please switch on your mic. We cannot hear you, Rumpa, ma'am. Yeah, your screen is on mute. No, your screen has to be yes, you've got it.
Okay. It's really an honor, Dr. David. I have been following you since 2016, and the person who introduced me to you is Larry Clark from Pardent. So me and Larry go a long way back, and because of him, I have started using Bioclear, and here there is Disha, there is Prateek, and we all are a team.
Anybody else would like to introduce? Please come forward.
Yeah. Hi. Hello, sir. This is Dr. Aditya. I am from Calcutta, and I'm an endodontist working since 2013. And Disha has introduced me to Bioclear, and she's so passionate. She keeps talking a lot about Bioclear, and I'm also here to take a lot of tips from here. Thank you.
Great.
Hi, Dr. Clark. This is like a fan moment for me. I've been following you on YouTube and all the channels that I can. I am with 3M India here. I'm the key opinion leader of the respirator line for 3M India. And I've been using the Bioclear matrices for class 2 and class 3 diastema closures, etc. for the past 2 years. And I do have a few questions that I can ask during the course of the presentation. Thank you very much for your presence.
I think we can start now.
Okay, all right. So I'm going to go ahead and start on the presentation. And some of you need to turn your microphones off because I think it's windy wherever you are outside. It sounds lovely though. I can hear the birds singing too. All right, so let's get started. Like Disha said, we have four learning centers now. We'd like to have a learning center in India. So we're going to start talking about maybe having a learning center in India. The question I have for everyone is, one of the things that's happened in the United States and actually in several countries is that we have so many patients now that are looking for the Bioclear method. They read about the Bioclear method. They see it on the internet. They see it on YouTube, on Instagram. And we have patients asking for certified providers that for Bioclear procedures. And so it will be interesting to see. I get a lot of questions from dentists from India and patients from India also about the Bioclear method. So it will be interesting to talk about having certification. In other words, Disha is a certified provider for the Bioclear method because she's taken certification training. So that's something that we can all talk about to see how much interest folks, the dentists you have in that. So so these are our faculty members that we currently have. These are our full-time faculty members. And we have faculty members not just in restorative, but also in pediatric dentistry, endodontics, and prosthodontics. And these are some of the instructors that we have. These are some of the Dr. Wen and Dr. Taras. They are instructors in the dental schools. So Disha, I am interested to see if we can help to work with some of the dental schools in India as far as the curriculum for the different cavity preparations. I will show some of these, if we have time, we have a syllabus of all the different class 1 and class 2 cavity preparations. So we're going to be talking about cavity preparations for posteriors today. And we're going to be showing some deep decay because Disha, you had talked about managing deep decay, correct?
Yes, yes, Dr. Clark. So Dr. Clark, we already have 2 colleges which I have visited, 2 universities in India. So one is my alma mater in Mulano, that is in Ambala, and one I have visited in Chhattisgarh Dental College, where we had a huge attendance of more than around 250 dentists who were interested in the, so India is all ready. The universities in India, I think, are ready to go ahead with the modern cavity preparations.
Great. So let's make sure that we will continue to work on that. It's so important to work with the schools. I think the schools in India are more progressive sometimes than the ones in the United States, at least when I visited. So that would be great because you know what? I had a patient in my office yesterday who had a GV black prep done 40 years ago and the tooth broke in half. It was a mess. And I shook my head and I said, I can't believe this cavity preparation, this GV black prep that people still do and people still teach. It's a terrible thing to do to a human being. It's a terrible cavity prep and the world still cuts that prep. So we have a lot of work to do and it's exciting and we're all going to do it together, right, Disha and everybody else?
Yeah, of course, Dr. Clark.
Yeah, I can't do it alone. I need a team of people to change the world, and we are changing the world, and we just can't stop, right? So it's exciting. All right, so these are some of the dental schools. We'd like to add these dental schools in India. So let's get to work on that. Let's add these schools to the map. Let's add these dental schools. Let's make sure that we have the names of the people at the schools who are responsible for the curriculum. We want to add them to the list and give them the information that they need. All right.
Yes, Dr. Clark.
Okay, good. So this is this is at the end of the presentation. If we have time, the Clark Cavity Prep's a syllabus for class 1, class 2, class 3, class 4. All of these. So we're not going to talk about selective caries retention today, but all of these cavity preparations are based on SCR. That's what we're calling it now, selective caries retention. Now, selective caries retention is going to replace old words. We have old words that we need to sort of retire. One of them is pulp capping, and we called it the Hall technique or modified Hall technique. It's now just selective caries retention. In other words, when we cut a cavity preparation with moderate to deep decay, we are planning on doing selective caries retention. So let me ask some of the people on our panel, what is the state of selective caries retention as the default procedure, as something that we do pretty much every time we have deep decay? Let's hear from a couple people. Where is India? Where are the schools with teaching selective caries retention? It's just starting in the United States. The dental schools are just starting to really teach this as a standard. Disha, can we ask a couple of people?
Yeah, everybody, please, you have to just unmute yourself and then you can answer it. Please unmute yourself.
Dr. Clark, I don't think so. The dental schools are emphasizing too much on this. But what's happening is because of our exposure to social media, and we are seeing cases all over on social media, etc., with selective caries removal. I think a lot of us have started doing it in our practices with rubber dam, and rubber damology itself is become popular in India past 2 years, past 2.5 years, I think. So yes, we are moving towards that.
Sir, you said selective caries retention. Am I right with the word? Yeah. So if we go back to the concept which was laid down for cavity cleaning or cavity preparation, then also this concept existed. They would not remove the complete caries from deep caries. They would always leave certain caries and then they would do the restoration. And there are studies that shows that the tooth was doing fine then. So if that is the terminology which you are following, what I feel is that we are more into infected dentine and affected dentine. So we try to remove all the infected and leave the affected dentine. That is the concept what we are following in college.
We're still following the infected and the affected dentine.
Yeah, we do. Yeah.
And then are we still telling them to put the dical and the GIC, or do they still follow that in the school?
Disha, that's what I'll go by the curriculum which is laid down by the standards of the Indian guidelines. Is that maybe the material has changed. Instead of putting dical, we are more emphasizing on MTA and biodentine. But okay. Yes, dical is also used. We still teach.
Okay, well, I'm going to interrupt. I'm going to interrupt for just a minute, and what we're going to say here very quickly is that I just wanted to get a feel for that, because it is something that is not an organized approach around the world. The world is very there's not a consensus, and so at the learning centers we build our positions for the way that we should begin to talk about and treat these teeth. And so I will send a paper, Disha, to you that is the official position of the Bioclear Learning Center's curriculum that we share with the schools. So I'll just cut to the chase right now. The conversation about infected and affected dentin, that's an old conversation. It's very simple now. The modern selective caries retention model is based on using a microsurgical approach and no longer chemotherapeutic. In other words, we're not using any liners anymore. Now, Disha, this is really interesting. They did a study in Brazil. This is great. They did a study in Brazil, and they did selective caries retention. And in half of the samples, they used Dical, and in half of the samples, they used wax. Wax, okay? Nothing. Wax. And in both, the caries were arrested. And in neither of the cases did the liner, the wax, or the Dical stop microleakage. So I'll just go ahead and let you, I'll tell you right now is we've moved beyond using liners, and we've moved beyond talking about affected or infected dentin. All we're doing now is getting a clean zone around the periphery that we blast the soft dentin so we have a good restorative seal, and that's all. So you'll see that.
Dr.
Yes?
Clark, just give me a moment. Dr. Sankit, I want you to switch off your mic. There's a lot of disturbance because of your mic. Will that be okay? Yeah, you've done it. Okay, Dr. Clark, we could go ahead because there was a lot of disturbance. Nobody could hear it on the Facebook. Yeah, now it's all good.
Okay, so in review, we are no longer relying on the chemotherapeutic model, and we're simply leaving decay. And we don't worry whether it's infected or affected. The most important thing is a 2 millimeter seal around the periphery. We simply blast away some of the softer dentin so we have a good restorative seal. And so that is the official position. But I'll send our position paper for you, Disha, and so that you can share that with your group. Okay?
Awesome.
Perfect. Okay, so let's go. So this is the Clark Class 1. One of the things about the Clark Class 1 and Class 2 cavity preparations is that the external seal is so beautiful, it's so robust, that's the heart of selective caries retention. With the GV Black prep, they tend to always leak, and so the success rate was less. So the seal is really the critical thing. This is a view of the Clark Class 2 with the infinity edge, and internally we have this area that we don't make this retention specifically for retention. This area here is based if there is decay. So this area that you see internally on this model was if there were decay in this area. So we don't, all of the internal aspects of the Clark Class 2 are defect specific. We only cut that if the decay is at the DEJ. And of course, there's almost always decay at the DEJ. That's why we're doing the restoration. So we'll show you a video of the modern Class 2. And then after we show the modern Class 2, we're going to go ahead and show deep decay. But we're going to start with conservative decay so we understand the model of the Clark Class 2. And this is the cavity preparation that is being taught in the schools for your certification for the board examinations. So this is the new cavity preparation that's being taught in the schools for the prep. I'll show you the perfect case here shortly, clinical case. All right. So the modern occlusal cavity preparations are number 1, a fissurotomy where we just have stain. Number 2 is the calla lily. I just showed you the calla lily. And I thank you for putting that beautiful, Disha, for that beautiful calla lily picture in your introduction. That is the beautiful shape. We'll talk about that. And then a flattened calla lily for endodontically treated teeth or very difficult cases. We will shorten the tooth 1.5 to from 0.5 to 1.5, and then have a calla lily for a challenging tooth or a badly cracked tooth. And then the cuspal overlay. So we'll show you examples of all these. The modern Class 2 cavity preparations are opportunistic, where we come in from the side of the tooth while we're restoring another tooth. These are all the exercises that we teach. These are the exercises that Disha did here at the Learning Center. Clark Class 2 is ICE. It's infinity edge, compression-based, and enamel-driven. And then a lateral cuspal overlay. These are a lot just to talk about in the beginning, I realized, but I just wanted to show you the different Class 2 cavity preparations. So let's get started. the Venn diagram that we have for the Clark Class 2 is 4 components. It's based off the scientific community, the research that's been done in the past, private practice. We're working with 3M, and we'll show you some of the research that 3M's done to validate the Bioclear method. We have a large number of doctors who've taken training like Disha at the learning centers that contribute to the curriculum, and the studies that we're currently doing in my practice and other practices. We're going to take a look at a little bit of the science that was done at the MDR-CBB, the Minnesota Center for Dental Research of Biomaterials and Biomechanics. This is really interesting stuff, some finite element analysis of the Clark Class 2 cavity prep, why the Clark Class 2 makes sense scientifically. So these are some of the studies that have been done on the Bioclear method. So the problem is, when you take a look at this composite, this happens to be a sonic fill tooth. I don't need a better composite. I need a better procedure. Everything about this thing is broken. There is nothing good about this preparation and nothing good about this restoration, but it's what we've done for a very long time. So I'm going to compare this GV black prep that's been beveled, that's been filled with sonic fill. You can see the recurrent decay right here. You can see the ditching around the margins. This is a sonic fill at year 4. Here's a Clark Class 1 calla lily that went from cuss tip to cuss tip at year 3. You can see that the wear, that the performance, the whole look of the restoration on the left, which is what most people are still cutting, versus the calla lily preparation over time, it looks completely different. So if we want to open up microphones, if people have any questions about the slide, I think that people are always sort of intrigued by the comparison of the old or the current way of doing a Class 1 composite with the calla lily, which is the opposite of a normal preparation with monolithic injection overmolding. Do we have any questions?
So since cavity preparation is so modern and it's minimally invasive, so do you recommend this cavity preparation when there is extensive caries as well?
Yes, and so we either do like I said, there's a fissurotomy, the calla lily, the flattened calla lily where we shorten the tooth, or if more than half of the cusp is gone, then we will overlay. It sounds like an onlay, but for direct, we call it an overlay. So we could remove one cusp, 2 to 3 millimeters, and then overlay 1, 2, 3, or all 4 cusps, depending on the case. So yes, between all of the different Clark Class 1 cavity preparations, no matter how deep the decay is, we should be able to do a direct restoration. I mean, at a certain point, certainly a gold crown is a nice idea too. But we can restore these teeth and put them into compression. I'm going to show you what that looks like as we go along. So thanks for that. Thanks for the question. So I want everyone to take a look at this quadrant of SAD composites. These SAD composites. So these are composites done here in the United States. You can see the gaps and voids that happen when you hand manipulate and layer the composite. We want to stop hand manipulating. We just want to injection mold the teeth. A very different process, which you'll see shortly. So with this Venn diagram, and Disha, is everyone familiar with the Venn diagram idea?
I'm not sure, Dr. Clark, if everybody is familiar, but most of them are. Yeah,
the Bioclear method is 4 different components. We talked about that last time. It's not just the prep, it's not just the composite, it's everything, right? The heating, removing a biofilm, all of those things. So this is based off the old Venn diagram. And I want you to take a look at this interproximal area. And I'm going to ask, I'll ask a couple of doctors. I want you to look into this interproximal area. So as I'm taking these teeth apart, I pushed the soft tissue back by putting in a diamond wedge. I brought the diamond wedges out, and I want you to look in the interproximal. And let me ask you something. With the normal slot preparation or GV black preparation, we're supposed to put the margin, we're supposed to keep the margin in the interproximal. Let me ask you, Is there anywhere in this interproximal that looks like it's a good place, a good home for a margin? Is that question understood? In a normal slot
Yes,
preparation,
Dr. Clark.
keep it in the interproximal. Is there a good place for a margin in there? Let me ask everybody.
Anybody?
I don't think so. It's a good idea, Dr. Clark. I don't think so. It's a good idea to place a margin there in the interproximal area because of a lot of reasons. I'm sure you will come to the reasons pretty soon. So I'll wait for your.
Thank you. Yeah. Here's the thing is that when we go to dental school, they tell us this is what you do. And then we don't question why. And that cavity preparation is from 1890. It doesn't make any sense, especially today with all of the refined carbohydrates. There is no good place to put a margin in there. And then I want everyone to look at this. What do you see right here? Can everyone see my cursor? What is that and where is it in the tooth? The histology of the tooth. What bad thing is going on here? These are composites that are only 10 years old. They're 5 to 10 years old. And what do you see right there? It's obviously recurrent decay. Where's the recurrent decay focused? Where's the recurrent decay centered? It's at the DEJ.
Yes.
The DEJ has to be the focus of our caries removal because a lot of dentists are leaving caries at the DEJ because the only way to detect for caries at the DEJ, you can't use a spoon excavator. Caries indicator is only marginally effective. We have to use the Clark Explorer or something like the Clark Explorer to probe the DEJ. I can almost guarantee you that the dentist who did this work left caries at the DEJ, partly because they was trying to keep the box in the interproximal. Because once the box goes out to the cusp tips, there's ruined the tooth. So because we have a broken mind about what the shape of the cavity should be, and we're not looking for caries at the DEJ because a lot of doctors don't use any magnification, we have the wrong brain. Are people following? Our brain is in the wrong place. We're not thinking about the true problems that led to the decay and that will lead to the recurrent decay. So nothing is more important than cutting a new cavity prep. And that's why the Clark cavity preps are based off of high magnification and the histology and the caries model that we see with primary and then recurrent decay. So we've got to change everything. All right. So what I would do in a case like this, and we'll talk about this as we go, is once I remove decay, and these are deep restorations, and I know that sometimes in India, your restorations are even deeper than mine. You all treat some pretty tough teeth sometimes. But what we're going to do is called deep margin acquisition. So I'm going to be packing cord in these areas, and then that will give me an ability to get access to these deep margins. And once I have access to these deep margins, this residual caries that I left in the tooth, it's going to heal itself. We don't need a liner. We don't want a liner because liners create more fracturing. It weakens the tooth. Liners are weak. They provide zero restorative seal. And so I know that we've taught MTA and some of these other things. Scientifically, there's no reason to do that. We just need a good restorative seal and to put the tooth into compression. So this is just a quick reconstruction of this arch using the Bioclear method. I want to talk a little bit about Dr. Dick Tucker. He's a famous gold wizard from my area, and he's passed away. We miss him, but he comes from a tiny little city in Washington. And Dr. Tim Hess provided these slides for me. Dr. Hess is going to be re-restoring this tooth with this broken amalgam. There's a break in the marginal ridge. So Dr. Hess is going to use a Tucker prep to cut, to restore this tooth with gold. And so when you look at this cavity preparation where it's flared like this, you look at the Tucker prep and it's flared on the class 2, and you also see on the occlusal, it's flared like a calla lily. So when Dr. Tucker redesigned the gold preparations, he told me there were 2 reasons. Number 1, so they could take the gold and swage the gold, burnish the gold, because a gold, Dr. Tucker felt that a gold foil was the best margin you could have. And the other reason was to remove the caries out of the disease zone into an area that was maintainable. So Dr. Tucker cut away a little bit of healthy enamel to put the margin out of the problem area. Doesn't that make sense? So I was thinking, I was trained by Dr. Tucker, and I realized that the Clark Class 2, part of my thinking was based off of the beautiful work of Dr. Dick Tucker and now Tim Hess, one of his students. And so here we are, and here's a comparison between the preoperative and postoperative. And you can see that the cavo surface area of the gold is 2 or 3 times as big as the amalgam. Now, sometimes people say, oh, the calla lily is too aggressive, or the Clark Class 2 is too aggressive. It seems like it's cutting more tooth away. But we've already done that with gold, because we know that we have to maximize the restorative seal by flaring all the walls in a modern way. These parallel cavity walls are bad in every way for composite and for engineering. So I thought it was neat to take a look at this at this gold work. And when you look at the pattern at aprismatic enamel and the pattern of cavitation, there's no good place to put the margin here. Look at all these class 2s. Where are you going to put your preparation? So if you're going to cut a little box preparation, you're going to leave aprismatic enamel at the margin. You're going to leave caries at the DEJ. So this is a model that's basically broken. So when you take a look at these Clark Class 2 cavity preparations that are flared, these are just just a shallow fissurotomy here on the occlusal. It's hard to see this, but these are not cut deep. These are very shallow fissurotomy areas. This is the Clark Class 2, a quadrant of Clark Class 2s. And so we're going to talk a little bit about the Clark Class 2, and then I'll show you the clinical video that really kind of puts it all together. So with the Clark Class 2, this case was done by Dr. Richard Young. The first thing we do is we disclose, then we pre-wedge, and then you can see that the cavity preparation is just created to find the DEJ caries. And then we actually bring a little diamond burr in laterally. You'll see that in the video to remove the decalcification. But Disha, this is a word that we're using now. I want everyone to know this. The shoulders of enamel, you know, shoulders, okay? The shoulders of enamel up toward the occlusal have been maintained. Even with deep decay, I can keep my shoulders, and the shoulders are here and here. Those shoulders are helping me to keep the wedge seated apically, and also it provides some support for the matrix and creates a great restorative seal on the occlusal. Now, what you don't see is there's a very aggressive radius bevel here, the radius wall that comes over the top to create compression. So that's the initial penetration. There is with caries removal at the DEJ, and then maintenance of the shoulders, and then removal of the decalcification under the shoulders in the waist area. So that's the idea. There's the biofit matrix. The neat thing about the biofit matrix is it's translucent. You can see through it. So we're able to get the infinity edge. If you try and do this with the metal matrix, you cannot cure the infinity edge. So metal matrices were built for GV black preps. And if we want to get true bulk filling, true injection molding, we really benefit from a clear matrix that has a lot of beautiful curvature to allow the matrix to sit away from the tooth. The matrix is not touching the tooth. The matrix is away from the tooth to allow the infinity edge. And there's the injection molding. We don't do any manipulation. We don't put layers in. We don't make deep grooves in the tooth. We'll talk about why that's a bad idea. We want gentle, simple, rounded anatomy, an infinity edge. And in these Clark Class 2s, we have mostly enamel because of the way that it's designed. We're minimizing our dentin cutting. We only cut into dentin to remove caries at the DEJ. and we're leaving the deep decay. With selective caries retention, we just blast it. There's no need for disinfection, no need for a liner. It's very simple. It's nice to have simple rules, isn't it? It's nice to make things simpler. Dentistry is difficult. So the Bioclear method makes things very simple, which is, I think, is helpful. So what I'd like to do here in just a minute is to start the video. Let's go ahead and take some questions about this case before we show the clinical video. Ready to show the clinical video? Perfect. Okay. Questions?
So Dr. Clark, I have a question. It's from Dr. Rohit. So he's asking me, where shall we use the blue color original series and where should we use the transparent, the HD series? So there's a lot of dentists who are having problems with open contact in the Bioclear when they're using Bioclear initially and they're starting to use with them, and then they shift from the HD to the blue ones. So that's a trend which is going on. But since I've learned from you and I know that we should use HD matrices, so I really want you to clear that confusion for everyone.
Okay, so the blue is thinner. It's about 50 microns versus 75. So you can get a little bit tighter contact with that, but the process that's called the push-pull process is incredibly powerful, and the HD is always going to be easier to work with because it's so strong, but we have to play the game. And the game is, number one, Disha, we have to pre-wedge. If you are not pre-wedging, you're not going to get the soft tissue out of the way. The pre-wedge expands the periodontal ligament. So for the 15 minutes while you're cutting the prep, the teeth are getting mobile and spreading apart. We have to use a powerful separator. Some people are using like a Triodent separator that doesn't have enough power. We need to use a twin ring that has enough power to push the teeth apart. And then the HD is, the HD is so much fun to use. So let's show how that whole push-pull process works. I'm going to show that, and then that'll explain why we can go maybe away from the blue. But we have to play the game, because I even got a few open contacts in the beginning with HD, but HD, we can go all the way to bone level with that. We'll talk about that, but it's a new game. So we're going to talk about the spot weld push pull technique. Okay, so let's go ahead. We're going to roll the video now. Let's study the modern class 2 procedure from start to finish. In the preoperative x-rays, we see incipient caries on the mesial of the first molar. We're showing various views with different levels of magnification and how the case presents clinically. Proper rubber dam isolation affords us many benefits, one of which is soft tissue compression, so we have access to the infinity edge. You'll see that benefit later. The cavitation occurred buccal to the contact, so I'll keep that in mind when I do initial burr penetration. Now we are applying disclosing solution, which is one of the first things we do in the procedure once the rubber dam is placed. We want to place the disclosing solution on a dry tooth. We'll quickly rinse it off with water, and now we're looking at this infinity edge area that is absolutely covered with biofilm. Placement of the diamond wedge is interesting. It needs to be kind of a slow process as you're gently compressing the papilla. We need to lift the rubber dam away on the other side. If we don't do that, you'll be fighting that rubber dam as it pushes the wedge backwards in the other direction. We want to push the flat end of these pliers against the wedge to continue to push it toward the buccal. You'll notice that the embrasure, the overall embrasure shape here is C-shaped, it's curved. So the benefits of this diamond wedge allow this to have this overall curvature that we would never have with the wooden wedge. It is key to continue to cuff the rubber dam once the diamond wedge is placed, to cuff the rubber dam actually under the diamond wedge to protect it. You see now I'm making initial penetration with the number 5 burr in the Comet Bioclear burr kit. We feel that the diamonds give us better control over cutting compared to carbide. Now what I'm going to be doing is remove the marginal ridge and get into the interproximal caries. We're going to be following caries at the dento-enamel junction. There's a couple of things we're not going to do. We are not going to break the contact with this larger burr. We're going to be doing that later. And we're not going to be worrying about axial caries, because in the modern cavity preparation, we are planning to do selective caries retention if need be. So what we're really focusing on here during this initial cutting is to chase the caries at the dento-enamel junction.
So as we move buccolingually and apically, we're actually creating a bit of an undercut as we go along, which may or may not be removed later when we do the radius wall through the enamel. I'm looking from the palatal. It looks like we still have caries on the palatal area of the DEJ. I'm now going to be rolling the mirror around, looking at the buccal. So we still have caries at the dental enamel junction. So I'm still going to be doing cutting along the DEJ, moving apically, buccally, and lingually right at the DEJ. Once again, I'm being very careful to stay inside of the cavity prep. That's the thing that we have to keep in mind during this phase. Stay inside the cavity prep. Simply explore caries at the DEJ. This is a defect-specific cavity preparation. It's going to be completely dependent on the caries, unlike previous models where there was an arbitrary cutting of the tooth. This is completely caries and defect-specific. So now I'm going into the palatal. As I evaluate the palatal, it looks like the palatal looks clean at the DEJ. The buccal under the microscope looks a little bit suspect. One of the problems with disclosing solution is we sometimes have false negatives. So what we find under the microscope is, if we'll take this Clark Explorer, which I'm going to show you in a minute, we'll take the Clark Explorer and probe soft dentin. We cannot leave soft dentin at the dental enamel junction. So as I'm applying disclosing solution, you're going to see that you don't see much decay here at the DEJ, but I'm suspicious. So I take the Clark Explorer and probe the DEJ, and sure enough, there is soft infected dentin at the DEJ. That must be removed, and unfortunately, that's being left in a very large number of cavity preparations cut today, because number one, people don't use a lot of magnification, and number two, they're not looking in that area. So let's look in that area. Now that I've applied disclosing solution to that softened caries that's been probed and disrupted by the Explorer, now it stains. So you can use caries indicator in a case like this after you probe the soft infected dentin at the dental enamel junction, but you can't use a large instrument like the old-fashioned spoon excavator. So we don't use spoon excavators anymore as far as caries excavation or for testing for soft dentin. We use diamond burrs to cut, and then we also use the very sharp Explorer, like the Clark Explorer, to probe that. We're looking at the caries that have been removed at the DEJ. That was burr number 6 from the Comet kit. Now I'm going to be cutting through this undermined enamel to begin to create the radius wall that will form the bulk of the enamel rod exposure during the cavity preparation. So this is a new skill that has to be acquired. So we're going to go ahead and basically section through that enamel to create the radius wall. One of the purposes of this video is to demonstrate how that we can cut this cavity preparation safely with a modern mindset and a modern armamentarium. There is a very high number of teeth that are unfortunately iatrogenically gouged during cavity preparation. And so you could see with these movements and with the proper burrs, and once again with the proper plan, it's fairly routine not to gouge the neighboring tooth. We're going to be leveraging off of the pre-wedge. Pre-wedge is essential for the modern class 2. So we're actually using the diamond wedge as a vertical stop as I am grooming the radius bevel on the gingival portion of the restoration. This protects the dam, the soft tissue, and more importantly, it actually gives us a vertical stop for our craftsmanship, so we can really direct the burr safely. So it's a new sensation compared to, of course, the old way of doing things, but we've tried to combine a safety factor and basic principles of burr movements to afford, number one, a great preparation, but number two, protection of the neighboring tooth and the soft tissue. So I'm still going after a little bit of DEJ caries there that I saw, and I am continuing to create the radius wall. It's no longer radius bevel, it's a radius wall. So you can see the burr movements. We'll do the final burr movements dry because we're not going to be generating much heat. We're in the enamel. So doing the burr movements dry allow me to see a powder trail. So I do not want my dental assistant blowing a lot of air here because I want to follow the powder trail of the diamond burr. Now this is burr number 2 in the Comet kit. We're going to use this for the radius wall on the occlusal. This is key to create a compression-based restoration. Let me repeat. This burr movement in the radius wall on the occlusal is key to create an area so that at the primary strike point, when the opposing cusp hits this tooth, that this area of the composite is in compression. So we've got to create a radius wall that's going to become tangential to the occlusal surface. So you'll see me move that burr accordingly. Now we are removing old composite that is on the occlusal. We're creating a calla lily here by using burr number 5 from the burr kit. So we're removing an old composite here, creating a compression in that area. And now we're ready to remove the pre-wedge. You'll notice that we immediately get some bleeding. So we're going to be able to manage that later with simple compression when the wedge is placed again. But we're going to go ahead and take an interproximal carver to remove any loose enamel rods or any calculus that might be apical to the bevel, because remember, we're going to have an infinity edge margin. So the next thing we're going to do is to take this diamond coated metal strip to remove any loose enamel rods, any biofilm that's apical to the bevel, because remember, with composite always goes past the bevel. So we have to turn a disadvantage into an advantage. It used to be called flashing. Now it's a good thing. It's the infinity edge. Once I've disrupted that subgingival area, I can go ahead and blast that. We're blasting the inside of the cavity preparation. Look carefully. We're going to be removing biofilm that's outside of the radius wall, because once again, with the infinity edge margin, we've got to clean the entire surface of the tooth essentially to the midline, because with the infinity edge, it may go that far. We're going to go ahead and optimize the shape of the neighboring tooth. The neighboring tooth did not have a good shape, which may have led to caries. So a contact is like a marriage. We have to have two partners working together. So now we've optimized the neighboring tooth. You can see the cavity outline from multiple angles with clean blasted enamel. We've aggressively removed caries at the dentinal enamel junction. We have all of the biofilm removed. The last thing that I'll be looking for is to inspect the cavity preparation to see if there's anything that I don't like. That can include caries at the DEJ or other problems. Now, what you're going to be seeing here in just a moment is what's called a stress riser. There it is. That's a potential stress riser in the composite. So we have to have a gradual transition from thick to thin, from inside of the cavity to outside of the cavity. That little stress riser there is going to be a potential problem. And not only that, it's going to disrupt the flow when we do injection molding. So I'm going to go ahead and try and smooth that little stress riser, but I'm going to have a little bit of trouble. And so instead, I'll bring actually the Softflex XT disc coarse in to smooth that area, a lot like we did when we did gold onlays and gold inlays with the Dick Tucker style of cavity preparation. So I was able to remove the stress riser there, and now we're ready to insert the biofit matrix. What we're going to do now is we have to press on the tab as hard as we can. Let me emphasize that again. Press as hard as you can. You cannot smash these matrices there. They are the HD version that allows us to take the matrix 2 millimeters apical to the bevel. And that's key to have an infinity edge and key not to have an overhang. Now we're going to bring the wedge in, and because the wedge seemed to keep backing out from the palatal, I'm going to change, and I'm going to go ahead and bring the wedge from the buccal. It is key. You must hold the tab down while you're inserting the wedge. You must hold the tab down while you're inserting the wedge to make sure that the matrix stays fully seated. So once again, I can't emphasize that enough. You must hold the tab very firmly over the marginal edge of the neighboring tooth while you're pressing the wedge into place. Now we're taking a look at the matrix placement to make sure that we like the position. You'll notice that that sort of almost concave area has been adapted to by the diamond wedge. We're now seating the twin ring separator. We want to seat that a little bit like a rubber dam clamp, and then the next thing you'll see is me rocking the twin ring apically. Now we're inspecting to make sure that we have a great seal. We have a beautiful infinity edge axis there. We're showing multiple angles of the entire assembly, and now we're ready to injection mold. This is the go, no go probe, and what we're looking at is to make sure that the cavity preparation is not deeper than 5 millimeters. And so the yellow line is 5 millimeters, so what that's telling me is this is a go. We don't need to do layering here. I'm putting a little bit of liquid etch first because that allows the etch to go around the corner, and then we'll go ahead and put in the gel etchant, phosphoric acid, And we're going to inject that gel etch around the corner out to the infinity edge. And then we'll go ahead and etch the entire portion of the occlusal that will be involved in that part of the class too. And we're going to etch just past the radius bevel or radius wall on the occlusal, so they have an infinity edge there. I'm going to go ahead and dry after etching for 10 seconds. And then we're going to massage the Scotchman Universal for a full 20 seconds into dentin tubules. This is key. And then before we licure, we're going to go ahead and do what's called the spot weld technique, which is mandatory for tight contact. So we're going to air thin. Then we're going to go ahead and bring the bulk fill flowable up and create a couple of spot welds. You'll see that in just a moment. Now I'm evaluating to make sure that all the dentin has been covered with the Scotchman Universal. So once again, we're going to be putting a little 1 millimeter button on the corners of the matrix, right where the matrix goes from horizontal to vertical. That needs to go outside, over, and inside the matrix on each button. This is the push-pull instrument. I'm going to take the matrix and push it over aggressively, with actually 2 hands, to create tension and great compression of the neighboring tooth. And that now that we have all this tension built up on the system and pressure, we'll go ahead and cure those little spot welds. That's going to guarantee a very tight contact and a very broad contact. Once we've cured the little buttons, we're going to go now in and cure the interproximal area that was blocked by the metal instrument. We'll cure that for 10 seconds. Now we're going to go ahead and do injection molding, which is 1, 2, 3. First thing is we're going to use the adhesive, again, as a surfactant. We will air thin that generous adhesive that's been placed in there, but not licure. Then we're going to inject with the bulk fill flowable at 90 degrees to the matrix tooth interface. Watch the flowable go around the corner almost all the way to mid-tooth. We want to inject to the edge of the matrix if we can. Then we're going to redirect the cannula, always injecting at 90 degrees to the matrix tooth interface. The uncured adhesive acts as a wonderful surfactant to get a void-free, complete infinity edge. All of that adhesive will be displaced and replaced by the bulk fill flowable. So once again, we've injected to the infinity edge, and now we're going to finish with phase 3 of injection molding, which is the Filtech 1 bulk fill paste. That's going to displace the flowable for the most part. And we anticipate that this restoration will be about 95% paste, or Filtech 1, as opposed to the bulk fill flowable. The flowable is really acting as a temporary surfactant for the paste. Now what we're going to do is to take this paddle and create a gentle central groove that's going to help us with C-factor. That'll help us with depth of cure as we make the restoration a little bit less deep, and it reduces finishing. We're going to cure from the occlusal for 10 seconds, and we shortened that just for expediency, but that was a full 10 seconds on the occlusal. And now we're going to finish 3-point curing by coming in from the mesial buccal. And of course, it's important to use an orange filter to protect your eyes, so we use that for just a minute to demonstrate that. And then we're going to go ahead and cure from the mesial palatal. 10 seconds, 10 seconds, and 10 seconds. Now, if you take a look, there's a quick release feature on the biofilm matrix that allows a quick release of the matrix. You're also going to enjoy the fact that because the mylar is much smoother than a metal matrix, it comes away easily and leaves a much nicer, smoother surface, which will, of course, resist stain, be more resistant to wear, and also be healthier than the surface that's imparted by a metal matrix. Now we're going to go in with burr number 1 from the Comet kit, and we're going to cut or section the composite exactly 1 millimeter from where we want the grade. We don't want to use this burr to do any margination. This is for simply sectioning the excess composite. We don't manipulate the composite anymore. We don't try and marginate it. We want to leave that excess at the marginal area so it shrinks toward the margins. And then we do the cut back. Now, as far as margination, that happens with the SoftFlex XT disc. The one thing to keep in mind is you want to make sure to keep that SoftFlex disc out the embrasure. That infinity edge area in the embrasure needs to be left alone, which is different than the way that we used to do it when we had more of a GD black or slot prep. Once again, I'm taking that SoftFlex disc. I'm going to change the position so it's no longer inverted. I'm going to create a mirror image of the neighboring marginal ridge. So it should sort of look like gull wings when you look with your mirror. In other words, each embrasure needs to mirror the other embrasure. It's so critical that the shoulders of each marginal ridge line up perfectly. So I'm looking with my mirror to make sure that those marginal ridges are absolute identical twins or mirror images of each other. That's going to avoid fracturing. It's going to make a much more comfortable restoration, Remember, composite is a brittle material. We have to put it into compression, and we have to remove stress risers, and we have to have nice, soft, rounded contours. And these restorations can last for decades if we understand the strengths and liabilities of composite. Composite is a brittle material. It's a wonderful material, but we have to manage it in a way that's appropriate. Now I'm taking that SoftFlex XT disc and carefully carving the buccal and lingual grooves. We feel that this is the safest way to marginate the composite. So we're not using the SoftFlex XT disc for polishing, we're using it for sculpting. As the disc softens, it becomes safer and safer to roll into those embrasures and grooves. I'll jump back to that burr number 1 from the Comet kit to remove the little vestige or the sort of the leftover connection that where it went into the tab. Sometimes we see doctors leave that little vestige, so that vestige has to be gently trimmed away. Now, on the occlusal of a posterior tooth, I love an old-fashioned brownie, and we're going to go in here and create that gentle primary anatomy. We're not going to make any deep secondary, tertiary anatomy that can lead to fracturing. The next thing we're going to do is take the interproximal carver and make sure at the infinity edge area we don't have any little bits of extra flowable or adhesive. You may see that on a radiograph later if you don't take care of that. The contact is amazing. It's broad. It's egg-shaped, like in the old days, or when I'm able to do a gold onlay with great, big, beautiful, rounded contours. This is the SoftFlex strip. We're going to bring it through on the coarse side first. And sometimes if you grab it with a hemostat in this position, so that it's easier to actually to polish that infinity edge. We'll take it through the safe zone, and I'll take it through on the smooth side. Some doctors won't do this step because they think it may mar the finish, but I hate to leave any little bits of adhesive there. You may see that on an x-ray if you don't do that. The next thing is the magic mix. We're going to bring the magic mix in these one-use cups, single-use cups. And what you want to do is pick up the magic mix with the cup and then roll it into the embrasures, roll it across your infinity edge. This is a great way of marginating the composite without aggressively removing too much enamel. So it really respects the composite and the enamel, but it does do a great pre-polish and kind of knocks off any little rough areas of flashing or excess adhesive. Now this is the Rockstar polisher. This is diamond impregnated and multi-use. And so we're going to be using this dry at first because it heats up the composite just a bit and is a good aggressive polisher. Now we go to the classic movement for the Rockstar polish. We're going to flex this cup using heavy pressure, constant air water from the assistant so that we don't overheat the composite, because now I've really tripled the force that I'm using in the wet stage of the Rockstar polisher. I'll flex that into the grooves. I'll follow it over the marginal ridge and into the interproximal. If you'd like, you can take the cone version of the Rockstar polisher and just refine some of that occlusal anatomy just a little bit. The primary anatomy is all we want. Once again, with composite, you cannot put deep grooves in composite and expect it not to fracture later. So I'm showing high magnification of just polishing the primary anatomy with the little point. We're going to go ahead and check the occlusion. And remember that composite is going to absorb 1% of its volume in moisture, so you have to leave it in slight hypoocclusion. I think it's a great idea, just to be safe. Once we've done all the polishing, to go ahead and repeat the 3-point curing. Once again, 10 seconds on the occlusal, 10 seconds on the mesiobuccal, 10 seconds on the distal buccal. We're going to go ahead and quickly equilibrate the case. We want to make sure, once again, and leave the tooth in slight hypoocclusion, because the composite is going to swell and absorb 1% of its volume in water. And so we really need to make sure that the little blue smudges on the composite are slightly less than the other teeth and slightly less where it's on the native enamel. So I'm carefully removing the excess occlusion there. We can quickly polish it with the Rockstar polisher. And that's going to be getting us close to the finish of the restoration. We'll check it one more time. Here is a pre-op and a post-operative radiograph. You can see the infinity edge. You can see the sort of different presentation of the Clark Class II radiographically. We're looking at the integration of the composite tooth to the tooth with the infinity edge. And there you have it. The Clark Class II procedure can be summarized with the ICE acronym. The I stands for infinity edge. The C for compression-based, enamel-driven. The asterisk represents the assumption that selective caries retention is the default position for axial caries retention in moderate to deep lesions.
All right. That's a lot of information. And you know what? That's 25 years of my life right there. It took 25 years to build that whole thing with the equipment, with the cavity preparations, the whole thing. So what we'll do is Carissa will send a private link to this video that you can forward to the doctors. We've still got to do a couple of edits on the video, but it's finished basically. And so we'll give you folks access to the private YouTube video of the clinical video. Okay, so I'm sure we have a lot of questions that we'll need to answer here. We can open up folks' microphones and take a look.
Hi, Dr. David. Hi, Dr. David. Can bulk fill be used instead of a normal composite?
Can what be used?
Bulk fill. Bulk fill compules.
Yeah, that was done with, go ahead and mute your microphone now. That was done with bulk fill. So with Filtech 1 and a clear matrix, I can cure up to 5 millimeters on the interproximal. Now, if it's deeper than 5, we're going to have to do some bulk fill flowable on the gingival to raise it up to 5, and then we can injection mold. And I'll show you a video on that, just a 3-minute video on that, on what do we do when it's deep, because we do a lot of deep decay, right? So this was a more conservative case on a kid, but we in the posterior, I use Filtech 1 for all my class 1s and all my class 2s. And I love shade B1. I just use B1 on every tooth.
We still don't have Filtech 1 come in. So we are using the Z350, XT Z350 for the anteriors, and we're using the bulk fill for the posteriors. So we're hoping that this year we would have the Filtech 1 in India.
Now isn't the 3M rep is here today, right? The lady, isn't there someone from 3M watching today?
We have Mrs. Sujit Hota, who's from 3M. Mrs. Sujit, please acknowledge.
Hi, Dr. Clark. Sujit from 3M.
Yes.
Yes, good to hear from you, sir. And yes, we are working on bringing Filtech 1 in this year. Well, soon, dentists will actually soon have the product in their hands.
Perfect. Yes.
I have been after him to get this soon. So, every time I see a video, I message him, I'm on this in India.
Absolutely.
Yeah.
We'll have it soon, doctor.
Good. The Filtech bulk fill was a good material, but it was not aesthetic. It was too translucent. It was not beautiful. And the Filtech 1 is so beautiful. I never have any patients complain about the aesthetics. So yeah. Let's take a look at the chat here. How do we manage, okay, so let's take a look at the cases. And I always get this question, what do we do about the hard stuff? What about large spaces where pre-dredging is not possible? And how do we use for deep root caries? So we're going to show that here in just a minute. So now we're going to go to, now that you understand the classic principles for the prep, really doing deep decay is not that different. So we can almost always pre-wedge. One of the questions from Aditya Shahabadi, it's early for me, Shahabadi, how do we manage large spaces where the pre-wedging is not possible? Pre-wedging is always possible. There is an extra large diamond wedge. It's huge. And if that doesn't work, you can put the extra large diamond wedge and then put a wedge underneath it to push it up. The reason we want to pre-wedge, even for deep decay, is it pushes the teeth apart while you're cutting the prep, and it does begin to compress the papilla apically, so we get a little bit less bleeding. I still want to pre-wedge every time. I want to try and pre-wedge every time. So that is the answer to that. Oh, you know what? I have a question I want to answer. I have a challenge. It's always something, isn't it? Now we go from deep decay to teeth with short teeth, right? I have a challenge with short teeth with management of any ring, especially the twin ring, right? So Disha, we have a technique that I'll send to you. I'll send a little video on that of how we make little buttons on, and the same thing on a canine or tooth that's poorly erupted.
You've shared with me that, Dr. Clark. You've shared how to put the button on the canine on the...
Yeah, okay, so Disha can show everybody later, because there are some teeth that no separator will stay on it. It drove me crazy. And then one day we figured that out. It works awesome. It works great. And so
Dr. Clark,
once you've done
Dr.
it,
Disha,
it makes
Dr.
sense.
Disha shared it with me too.
Okay.
Yeah.
That was Dr. Anuj. I shared with him the technique. Yeah.
Yeah. So do you have a video? You need to make a video.
Yeah, okay.
We'll do that.
Yeah. It works. Yay. So we're going to be showing some techniques for deep class 2s, which we do a lot of, unfortunately. So we'll talk about doing what's called deep margin acquisition. So let me I think now the matrix that you saw, nobody asked about this, Disha. The matrix that you saw in the video has print on it, did you see that?
Yeah, it's a new one.
Yeah, it's a those are prototypes, and then we're going to have all the biofit will come at up to 9 millimeters, because I need a 9 millimeter and you need a 9 millimeter, right, for deep decay. Yes. Yay! We also have a new broad flat molar. It does not have a lot of emergence profile. It's for narrow root spaces, like between the upper first and second molar. Sometimes the roots are close, and the matrix inverts, doesn't it? See, I work every day. I got to go do dentistry in an hour. So I have the same nightmares that you have. And every time I have a nightmare, I go back to the lab and I think, okay, we got to fix this, right? So there'll be two different biofits. One is the normal, beautiful shape, and one is very, very flat, very broad for between upper molars. That's a unique problem there, but it's a problem, right? So, but what I wanted everyone to look at is in that video, I took the biofit matrix, and how hard did I push the biofit matrix? Let me ask everybody. How hard did I push that thing?
Very hard.
No. Not very hard, Anuj. As hard as I can. Yes. Difference. As hard as I can. Now, what would happen if you did that with a blue matrix, with a biofit blue or a metal matrix? What would happen if you pushed as hard as you can? Anuj?
We're dead.
Yeah. It would cut your thumb with metal.
As well as the gums.
Or it would smash. You cannot, biofit is it's stronger than steel. That's important. So the spot weld push pull technique, before we had that instrument, before I understood that, I would get light contacts. But the biofit HD is so much stronger than any other matrix that it allows us to go to bone level if we need to. And if we understand pre-wedging, if we understand the push-pull spot weld push-pull technique, and we're using a strong separator, you can push the teeth apart 400 microns, okay? The matrix is only 75, but we have to play the pushing game. And that involves a pre-wedge, that involves a strong separator, the twin ring, and it involves loading the matrix, pushing the matrix over, and distorting and expanding the matrix to make a really broad contact with the push-pull spot weld. You can't do that with just the cotton pliers. You have to do the technique. And I know it seems, that's crazy, Dr. Clark. We never did that before. Well, everything is new, right? And it works. Man, they're beautiful. It works every time. So
I would agree. I would agree to that.
Disha,
yes, please.
Is it possible to interrupt? Is it okay?
Yes, please.
Please.
Yeah. So beautiful restoration. I just have a few doubts that how is this Clark Explorer different from the Shepherd's Hook of a regular Explorer? Can we use a regular Explorer also to see the caries in the dentino-enamel junction? I mean, how different is it?
Who is asking this question?
Dr. Laura.
That's me.
Ah, Dr. Laura. Okay. The Clark Explorer has two features that are important. Number one is that I am using the endodontic end of the Explorer, not the shepherd's hook. The endo Explorer,
Okay.
great, because I've got to push pretty hard on that area. Number two, a standard Explorer is too flimsy, too thin. I can't put enough pressure on it, and a standard Explorer does not stay very sharp. So that Clark Explorer, it's titanium coated, has a very sharp tip on it that stays sharp. So the Clark Explorer, or something exactly like the Clark Explorer, is needed for DEJ caries. It doesn't have to be the Clark Explorer, but it has to act exactly like the Clark Explorer. That's the way everything in the Bioclear method is. It's very specific for the goal. Does that make sense?
Yes, sir, it does. So if so, you use only Clark Explorer as one of the hand instruments, or do you use any specific hand instrument to refine your cavity, especially at the gingival margin area?
No.
Thank you.
Dr. Clark,
You can
Dr.
sell,
Disha
you know what?
showed me-
You can sell all those hand instruments on OfferUp or eBay or whatever they have in India, okay?
Dr. Clark, you wouldn't believe Dr. Disha showed me the difference between both the probes, and I was amazed. Right, Disha? Remember?
Oh, yeah, the Explorer, yeah.
Dr. Anuj was there with me, Dr. Clark, for 2 days, and we were in a clinic from morning 10 to night 10 o'clock. So we had a lot of.
It was amazing. I just can't tell you how good that was.
Right. Everything with the method, you need to, and with the reason we want, Disha wants to do hopefully a learning center someday, with the reason we want to, you need to test this with your own hands. Every single thing with the Bioclear method has taken 25 years to build, and it's all built off of nothing else works exactly like each individual thing. So each individual component was picked specifically, and if you change one thing, it starts to become less consistent, right? Less predictable. Yeah.
Dr. Clark, we have a question from Facebook. Can I go ahead?
Sure.
Yeah. So this is Dr. Rishabh Pendurkar. He's asking that, as Dr. David Clark said, the contact point is a marriage between two teeth. What if the anatomy of the adjacent tooth is not favorable for the contact development?
So so the question is, David, it's a marriage, which is, I'm glad everyone's listening. People are, even though it's late there, people are listening. You must have had some tea to keep you awake, okay? So we want, for a contact, we want to come away from the gingiva, come together for 2 to 3 or 4 millimeters, and then come apart, right? Come together, come apart, right? It needs to be in the middle of the tooth, or in the junction of the middle and the coronal third, right? And so if the neighboring tooth is sticking out like that, you need to take the disc and make it upright. The contact should be parallel to the long axis of the tooth, not like that. So if there's a tooth that's sharp, it's leaning over, you cut it back. Sometimes if the shape is weird like that, or it's a concavity, we'll do additive dentistry. We'll do opportunistic access, come in from the side and remove calcification, add flowable composite so that the other half of the marriage is perfect, right? And so sometimes we can add to the neighboring contact if subtraction is not the right idea. Usually a little bit of subtraction is what we need. Sometimes we do a little bit of addition and then we subtract, and that's one of the exercises that we teach in the posterior certification, is how to optimize the neighboring contact. But I'm glad that you're listening, and that's a very good question. So there's 2 ways. We can subtract, or then add flowable composite and then subtract. We only need flowable there because we don't chew on that area. It's an area that's not going to get loaded. So we use just the bulk fill flow there after we disclose and etch and go through that. So that's a good question. We've got a case. I got another question from Aditya Shahabadi. See, I'm getting that down. Aditya Shahabadi asked, man, she's got a lot of questions. In cases where we've lost the enamel at the DEJ, do we need to do a hip first? No, not anymore. That was called deep margin elevation. We're done with that. We do hips for other reasons, not in the class 2. I'm going to show you what we're doing for bone level caries. Now, it's going to be helpful when you have that 7, 8, and 9 millimeter biofed, okay? In the meantime, Disha, people can use the HD-A104. That's an anterior matrix, but the HD-A104 is an 8 or 9 millimeter matrix. It's very tall. Just trim the gingival. You can use that for deep margin, what we call acquisition now. So I tell you what I want to do. I want to stop for a minute. We've got about another 20 minutes, 20, 30 minutes, and I'm going to have to run off. I want to show a little bit of the science, and then I'm going to show a deep margin acquisition case, and then I'll show a bunch of deeper cases, and that was one of the questions that we had. And you'll see also our selective caries retention, what that looks like clinically. Okay? We good?
Yes, Dr. Clark.
All right. Well, these are great questions. The questions that you're asking tell me that you really are engaged. You're doing this clinically. These are great questions. I'm really happy about that. Okay. So this is some of the research that was done. We did what's called finite element analysis of both the Clark class 1 and the calla lily versus the black class 1, and then a black class 2, slot class 2, and the Clark class 2. So what we're going to be doing is we're going to be measuring shrinkage stress, which is interesting. So everybody worries about shrinkage stress. I got shrinkage stress. I need to layer or do something. The comparison between the black class 1 and the Clark class 1, this is very interesting. Most in the Clark class 1 and that calla lily, a lot of this stress distribution is occurring in enamel, not dentin. And we know that an enamel bond is something we can really trust a lot more than dentin. Dentin's okay, but in enamel, I trust. So let me back up here. So with the Clark class 2 versus the black, we have a lot more of the stress occurring in the enamel, which is a favorable thing. So here's the Clark class 1, there's the black class 1. And then when you blow this up and take a look at it, everything in blue is actually compression. So this is really interesting. Now there's a little bit of scatter red over here that's just scattered. You can discount that. But in the area here, almost all of the interface areas anywhere near the margin are in compression. So as the composite shrinks, it actually shrinks toward the tooth instead of opening up the margin. So that's why on these cases that you see, you don't see those margins opening up over time. Let's take a look at the Clark class 2 versus those other 2 preps. We've got a GV black prep and a slot preparation. And here really is pretty interesting. You take a look at, once again, in the Clark prep, the bulk of the polymerization shrinkage is occurring against enamel, not dentin, which is going to be very, very favorable because we trust enamel adhesion. I want to blow these up. Once again, look at this ocean of blue. Look at this ocean of blue. That's where the composite is literally shrinking toward the tooth. So this is what's really interesting. We believe that with the Clark class 2, that the polymerization shrinkage is a favorable thing. Now out here on the red, this is all just scatter. So I don't should be distracted by that red right there. So this area of compression here provides an incredible ability to seal the tooth for a very long time. And that allows us to do selective caries retention here. If I've got selective caries that's been retained here, we don't care because we've got this amazing seal out here. Now with the slot preparation, look at all of the high polymerization shrinkage stresses around the margins. These are all going to leak. They're all going to leak on the gingival, and then your selective caries retention is not going to be as effective because you're not going to be able to seal the decay and let it heal itself naturally. So that's some of the work that was done, and I'm excited that I can show you this work. That work was funded. I want to thank 3M for that. So here's the problem with the normal class 2. Almost all the margins leak. You saw why, right? All the stress that occurs at the gingival, plus there's biofilm. There's a metal matrix. We're not getting a good cure. Here's afterwards with the Clark class 2, the infinity edge. that's what we want to do. And even if the area, even if there's deep decay on the cementum down here, it doesn't matter. We can still get a reasonably good seal here, but then all the occlusal seal on the enamel will keep the restoration from debonding. That'll keep the restoration from falling out, basically. So we don't call it a margin anymore. It's the TRI, or tooth restoration interface. It's a whole new game. First thing we've got to do is we've got to change the shape of the prep. So once again, we're not going to cut a GV black prep. This is the Clark Class 2. We've got disclosing. We've got to remove the biofilm all the way pretty much to mid-tooth. Then we're going to have an aggressive radius wall on the occlusal, aggressive radius walls here that allow for the infinity edge. And then we're going to do additive dentistry. This zone in the light green, that's where we're adding volume. The tooth is going to grow. The tooth is going to get a little bit bigger. What does that allow us to do? We get a bigger, better contact. So if you're having trouble with broad contact, if you're having trouble with contacts, part of it is that you're not allowing for additive dentistry. That will physically make the contact broader. Now, Disha, this is one of the interesting things. Even in cases where when I look at the x-ray or I floss, it doesn't seem as tight as it used to be in the old days of burnishing, because the contact is so broad, the patient does not get food impaction. So in some of the cases where I'm disappointed that the floss doesn't feel as tight, remember that contact is so broad buccolingually that it's physiologically healthy, even if it doesn't have a really tight snap of floss. So let's go ahead, and I want to show, well, we've already shown this Class 2 clinical video. We're going to talk about deep margin acquisition, and then I'll show you the video on how to combine the deep margin acquisition with selective caries retention and the spot weld push pull. So we'll put it all together in the video. We're going to pre-wedge, and like I said, even in the largest embrasures, the extra large diamond wedge, it's a big wedge. Don't remove the papilla. I know in some places, I know in Italy, a lot of times you see them remove the papilla. I want the papilla. We're going to displace the papilla laterally. We're going to take some cord that's been soaked in hemodent, and we're going to pack it aggressively. And that's the problem. Nobody's packing it hard enough. You're actually releasing the periodontal ligament when we have deep decay. You're releasing the periodontal ligament with cord, just like a very deep crown margin. I want you to pack cord till you can see the bone. And then once that soft tissue has been released from the tooth, that will allow the matrix to slide all the way basically near the bone. If we want to have a great restoration with Bioclear, I want the edge of the matrix to be 1 to 2 millimeters past the bevel. Did everyone hear that? I want the matrix to go 1 to 2 millimeters past the bevel. And the only way that you're going to get that to happen is to do what's called deep margin acquisition, which we're going to show you. Once you've done that, the matrix should slide all the way near the bone level. Sometimes we have to trim the corners of the matrix to have it do that. We'll show you that. Now, sometimes we don't use a wedge. Sometimes we cannot use a wedge with deep margin acquisition because the wedge will literally sit in the cavity prep, inside of the cavity prep, because it's so deep. So sometimes we won't use a wedge because remember, the twin ring separator provides more pressure than the wedge. And sometimes we'll just put the small wedge in. These are courses that hopefully we can teach because it will make a lot more sense when you've done the class with Disha or someone else teaching this. So deep margin acquisition is what we call it now. It's not deep margin elevation anymore. We've moved beyond that. So here's the problem. Look at this. This is not my case, obviously. This is a case. It was from a dental school sent this to us. It was a dental student did this, and they obviously failed the test. But this was a radiograph of where they did not get access to the deep margin. There's multiple problems in this preparation, and it's really always about the ability to get access to the deep margin. That's what we have to start focusing on, is getting access to the deep margin. They obviously did not. So here's a case that I had to retreat. This is a composite that was placed about a year before. There was already recurrent decay. So these are just high and low contrast radiographs. I've got to redo this composite here. Unfortunately, this is where the x-rays were sent to me by the doctor who treated before. This is where he started. This is where it ended up. What a mess, right? This is not a fun case to do by any means. So here we go, deep margin acquisition. So here's the case. I'm retreating the composite that was done just a little while before. Once again, you see these GV black margins that are ditching. I'm going to be doing an overlay on this case because there's just not enough tooth structure left. I'm going to go ahead and pack cord. We're going to pack cord all the way to bone level. So you can see this cord, it's going near the bone. And now you can see I've got selective caries retention here internally. And now you can get a very good look at the way I've packed cord all the way to bone level. So I'm going to show, I did make a mistake in this case. Once we remove the cord the first time, we blast it, put the cord back in, take it right back out. The cord does not stay in. The cord goes in, goes out, goes in, goes out. We blast in between. So there you go. There's this beautiful blasted enamel. I can see the burr marks there. That's why I like a diamond burr. I can see that the dentin is hard. You can see the selective caries retention internally that we always do in a case like this. Once again, we don't put anything over the selective caries retention. There's no need to sterilize it. The body will heal itself. The body is amazing. There's my beautiful margin. I did make a mistake here. I should not have used the wedge. I'll show you later what happened when I put a wedge in there, which I really didn't need to do because it's going to make a concavity. This wedge is actually sitting inside of the cavity prep. You just can't see that. So that's a pretty good looking margin. We're going to put down a millimeter of bulk fill flowable here. We'll do the push pull and then we'll light cure. So there's the deep, I've covered up the deep area. I've got this is back when my spot welds were not very good. You can see Disha would be saying, Dr. Clark, what happened? I didn't get my flowable over the matrix. So you've got to get the flowable over the matrix to hold it. Rockstar polish. Once again, we want the occlusion to be light because the composite is going to absorb a little bit of its 1% of its volume in water. So always leave the blue mark on the composite a little bit light. And there's before and after, and you can see that the one problem I had was I should not have used the large wedge there. I didn't need a wedge, or I could have used just a small wedge to put a little lateral pressure. But other than that, I'm pretty proud of that beautiful contact there. Here's a beautiful margin. Here's another case with deep margin acquisition. You can see that preoperatively the decay is quite deep. I'm going to go look how close I am to bone here. It's not a problem. And there are some studies done in Italy showing that you can actually get a millimeter or two closer to the bone than in previous thoughts because of how good the composite can fit compared to a crown. So once again, we disclose and blast. 2 millimeters of cuspal clearance. I did cuspal overlays for this. Here you can see the selective caries retention. This is a lateral cuspal overlay. I was able to maintain my shoulders. Now for deep margin acquisition, I did an opportunistic on the neighbor. We're going to remove the pre-wedge. You're going to pack the cord soaked in astringent, take it out. Then you're going to put in the matrix. And excuse me, in this case, you actually, I think I missed this. We've got to pack the cord twice. I've got to update that slide. Yeah, I packed the cord twice. I was able to use the diamond wedge here because my shoulders were maintained. So there it is. There it is. There's the opportunistic access on the neighbor. There's my selective caries retention, always 2 millimeters away from the DEJ. There's a lingual view. So yeah, pack the cord, remove it, and pack again. So we pack the cord twice, and man, you really have to push it hard, almost as hard as you can. In this case, because my shoulders were intact, I was able to use an extra large diamond wedge. Most of the time, you probably won't be able to use it, but I was able to maintain my shoulders. So the wedge is staying apical. It's a beautiful margin. I'm a millimeter from bone right there. Can you believe that? We do it every time now. It used to be hard. Now it's easy. Isn't that amazing? It used to be so hard. And now it's just every day, no problem. Easy, easy, easy. We have a beautiful recipe, beautiful system to follow. There it is, simple anatomy. This patient had zero postoperative pain, zero postoperative pain. So I am firmly in the belief that you can grow your practice by doing these Bioclear procedures, letting patients know how comfortable that these procedures can be. And so we use the extra large diamond wedge as a pre-wedge. In this case, I was able to keep it because I had shoulders on the prep. the push-pull contact. If I would have done a push-pull on this contact, my contact would have been better. I did not use the push-pull back then. If I had used a push-pull, that contact, instead of being a point contact, would be more broad. Okay, so now I'm going to show you the deep margin acquisition video, and then we'll take some quick questions before I run off. So let's go ahead and start the video. Disha, are you there? Can you hear me, Disha?
Yes, Dr. Clark, I'm here.
Okay,
I can hear you.
Good. I'm going to go ahead and then, where's the panel? You get the panel up here. I minimized the panel. Where are my people? My peeps. There they are. Good. Okay. I want you to give me a thumbs up if you can hear me talking, okay? On the video. All right?
Hi, it's Dr. David Clark from the Bioclear Learning Center. We're going to introduce the chapter 5 of the BioFit series. Today we're going to be focusing on deep margin acquisition for moderately deep recurrent decay underneath an old composite in a class 2. Number 2, the spot weld / push-pull technique for 100% broad, beautiful contacts in a difficult class 2. Number 3, layering for depth of cure when the cavity prep is deeper than 5 millimeters. Number 4, the new bubble-free bulk fill flowable by 3M, which we're really excited about. The last note about this case is this is a case that was funded by a third party, by a government agency, so I'm only doing the deep decay that's on the distal of the bicuspid. There's some other areas where the composites are sort of iffy, but we were not going to be treating those today. So it's just the distal of the bicuspid. All right, let's go.
So we always disclose that we do that in the very beginning. You can see this leaky pore composite here. I'm going to put the large pre-wedge in. We always follow the same sequence, the same burr. I'm going in, I'm cutting, looking for DEJ caries, not worried about breaking the contact. There is the removal of the diamond wedge. You see bleeding. We don't care because we're going to do deep margin acquisition here. We put a lightning strip in here first to clean up the any bits of rough enamel. I'll remove calculus with the scaler. I don't care about bleeding. Now we're going to pack the cord. And Disha, we are packing this cord. You got to go to the gym and work out, okay? We are packing this cord as deep as we need in this case to bone level to separate the ligament temporarily. Now the cord comes out. Hey, no bleeding. We blast in between the two packing of cord. So the cord goes in. Now we're going to blast inside the prep and outside the prep. I used to blast in the beginning. Now we blast at the end. Now I'm optimizing the neighboring contact. I'm going to pack the cord one more time just for a second. I've soaked it in Hemadan again. We take it out. Now I've got access to bone level. I like to trim the corners off of the BioFit HD on the traditional traditional BioFit matrices because I've got to go a little bit deeper on the interproximal because that's where I did my deep margin acquisition with the cord packing. So now I'm going to put it on there. And then how hard am I going to push on this?
Very hard.
As hard as I can. Hold the tab and down. Bring the diamond wedge in. Always holding the tab down. I don't care if the contact's open. We're going to close it with the spot weld technique. We got to use heavy separation with the twin ring separator. I like the bicuspid. It has good power. Once again, the contact's open. Don't care. It's not a problem anymore. I like a little liquid etch just to make sure that I have an etch all the way to the infinity edge. Then I'll go ahead and use the gel etch because I can see the color there. So I'm just being kind of fussy with that. We're going to rinse and dry. This is about 6 millimeters deep. So we're going to have to do a 1 millimeter increment on the gingival. So in this case, we're going to do a 3-point spot weld. We're going to go ahead and put 1 millimeter flowable in the middle of the interproximal, and then we do our spot welds on the corners of the matrices, and now we're going to do the push-pull. So we're doing two things at once. Number one, we're adding a millimeter on the gingival so that we are only at 5 millimeters, and we're doing the spot weld. And I'm pushing with 2 hands, okay? I'm pushing hard, expanding the matrix, and it's going to be amazing. So now we're ready for injection molding. We have to cure once the push-pull instrument comes out because it blocks the light. So now we're ready for traditional injection molding. This is the part where you can relax. Everything is great. I looked clinically. The contact looked awesome. The contact was broad. The matrix inverts a little bit to create a broader contact. Now this is just classic injection molding. We cure the occlusal. We have to cure from the distal buccal and distal lingual with 3-point curing, release the matrix. Remember, always look for the little quick release with the Biofit because it makes it easy to get the matrix off. We cut 1 millimeter from the tooth, just the same as last week when we talked about the anteriors. We cut 1 millimeter, then we bring our disc to marginate and marry everything together. And then we take a strip across the interproximal, same thing. And then we will bring in the magic mix and Rockstar Polisher. And now we have this beautiful compression-based restoration that shouldn't leak and should give us hopefully 20 years of service. So that is something we've never seen before with composite. So I've got about another 5 or 6 minutes so we can ask questions quickly. Once again, we're going to give you links to both of these videos so you can watch these later. So let's take any questions from the group. How do I max up all the attendees?
Hi, sir. Beautiful restoration. My question is that since if the caries is more focused at the dentine area, I had asked this question last time, but somehow it was not answered. So I'm asking you this directly. Do you do selective etching?
We no longer do selective etching. One of the nice things about Scotch Bond Universal is that acid etching the dentin does not inhibit the bond of Scotch Bond Universal. In fact, it can even help it a little bit. One of the things that happens is that under the microscope, because most dentists don't use microscopes. And most dentists in North America don't use microscopes, actually. I'm less than 1% using a microscope in North America. So people don't see what crazy Dr. Clark sees, okay? I've been looking at this for 25 years. You cannot selective etch because when you look under the microscope and you put etch on the tooth, most dentists are not etching all the enamel and they are getting etch on the dentin. They just can't see it because they're not using a microscope. So for the Bioclear method, it works much better to do total etch. So selective etching is one of those sort of old conversations, like liners, like direct pulp caps. These are conversations that we don't have anymore because we moved on to a very simple method. So,
but if the caries is extending too much close to the pulp, so you mean to say these?
So but we remember we do selective caries retention. So we never get pulp. So
if the caries extension is that deep, then?
We always leave a buffer of selective caries retention over the pulp. So we're never going to acid etch anywhere near the pulp because the new cavity prep does not expose the pulp. And we don't even get close to the pulp. We just get 2 millimeters of seal. So on the cases that I showed you, even though they were deep, the pulp was really not affected by the restoration. So in the old world, we did selective care. We would do selective etching. In the old world, we would try and remove all of the infected dentin. In today's world, we don't worry about removing infected dentin. We're leaving a barrier of nature's dical, okay? Selective caries retention is nature's dical, and nature always knows best, doesn't she? Nature always knows best. Nature's dical is better than artificial, than man's dical. So we don't worry about the pulp because we're doing what's called a pulpally protective caries excavation. See, the problem is, Laura, is that we have our brain in a Venn diagram with a cavity prep that always gets too close to the pulp. Then we have a million problems.
Yeah.
With Bioclear, we get to have a new conversation. We started over and we threw away about 80% of all the old stuff. So whenever we're talking to our colleagues, Disha and everyone else, you have to ask yourself, and I'll send you the position paper, is this an old conversation or a new conversation? So when someone asks a question like selective etching, that is a old conversation, right? And then we have to gently redirect that and say, in the old world, that's the question that we ask. We don't ask that question anymore because we have a pulpally protective caries excavation, and we don't care where the acid etch goes. So and here's the neat thing. We have at least 15 dental schools that are doing it exactly the same way. That's the first time in a long time that every dental school that's working with Bioclear does it exactly the same. So we're able to have new conversations, and now we're doing research on the new Venn diagram. Isn't that exciting?
Great, sir. Thank you so much. Before I mute myself from the presentation and let other people get into the discussion, one last question is, what is the abrasive wear resistance of this material?
Of
this composite compared to the other composites which are available in the market.
Filtech 1, it has about the same as Filtech Supreme Ultra. It's beautiful. Yeah.
Compared to the tooth.
Oh, about the same as the tooth.
Yes.
Yeah.
Thank you so much.
Ultra. I have 2 more minutes. Okay, we'll take one more question.
Dr.
Sorry. Go ahead, Disha. Sorry, I
I'll just ask you questions from the Facebook because many people are asking questions there. So Dr. Sushen Sharma is asking, is a bevel recommended at the gingival floor of proximal part of the cavity prep?
So you have to ask the question, and we want to redirect that question because that's kind of an old conversation, okay? Yes. We have to be, because we use magnification now. Is it dentin or enamel? So if it is enamel, we always bevel the enamel, but we don't just bevel the enamel, we go past that beveled enamel onto infinity edge, which is clean, uncut, etched enamel. What about dentin? You know what? The research will tell you that the composite always goes past the margin. There is no margin with composite. It always goes past. So what I'm doing today, Disha, I'll do a very, very tiny bevel on the dentin just to make sure that it's clean. And you know what? We do know that a beveled margin has better C factor than a butt joint. So if you're going to put a butt joint down there, you should either use amalgam or composite. But if you're going to have a margin on enamel, I want a big bevel. On dentin, I want a little tiny bevel. But I still put a tiny bevel on the dentin to improve the C factor. But regardless of what you think you're doing, composite always goes past the bevel when they do the research. So you need to blast that area, scale it, and the biofit matrix is so curved that it allows the composite to always go past the margin just a little bit. The biofit matrix was built for modern composite. We're not talking about margins in an old sense anymore. So that is the story. I'll take one more question, then I got to run off and do an exam.
Dr. Harsh, please go ahead.
Sorry to interrupt, Disha. Thank you once again. Beautiful restorations, Dr. Clark.
Thank you.
I have a question regarding the degree of bevel you give to your cavity preparations. What degree of bevel do you give occlusally as well as proximally?
Okay, here it is. Can we zoom in on this?
Yes.
That's the radius wall. The entire enamel wall is a radius. It's not a bevel anymore. In fact, the word bevel is actually an old conversation. We have a radius that becomes tangential from the inside to out. And Disha, here's the great thing. Disha knows all this stuff, okay? I'm just the old guy. She's in charge, okay? So the radius wall is what we're talking about now. The entire enamel substrate is one arc. It's a radius. So that's not really a bevel anymore, is it? So we call it the radius wall. The only place that's beveled would be the gingival. It's hard to put a radius here because it's so hard to get through. That's more like a standard bevel here, but everything up here is a radius wall that becomes tangential. And if that doesn't make sense, Disha can show you preps and some other things. And when you look at that video, you'll see that the radius wall is what we're talking about. And here's the thing, there's no mechanical retention for these preps. We don't need it if we create compression at the primary strike point. And remember, here's the next thing. Today, we're talking for an hour and a half. We need about 200 hours for you to see all the things that we've developed with the Bioclear method. So today is a great step forward. And there are 1,000 conversations that we need to have in the new world, and they're fun and they're exciting. I mean, the thing about Bioclear is people say it's fun. I'm an old guy and I'm having fun, man. I mean, it is so beautiful, right? Because it just makes sense. And we're able to ignore all the old stuff that was never really based in science anyway. I mean, when you look at selective caries retention, we're talking about 97% survival. 97% survival. With direct pulp capping and MTA, 50 or 60%. That's not acceptable. So the science is now supporting the Bioclear method. And so there's a bunch of studies that we can share also that describe that. Well, I have to go. So Disha, this has been so fun. And
this is amazing, Dr. Clark. I mean, you've spoken so much. What I registered in one day at the center, I think you shared almost in like 1 hour. So that's amazing. Thank you so much for accepting our invite. And, you know, it was really fun to have you. We could meet you, interact with you today. It was great fun. It was great fun. I loved hosting you, Dr. Clark.
Well, I love being hosted by you. I've been to India a couple of times, or how many? Once. I've been once. Yeah. Anyway, I love my trip to India. Hopefully, come back someday. But we're very engaged, we're very supportive, and yep. And we want to work with the school. So let's make sure that we get that. Okay.
Yes, we can have that.
Very good.
Anybody else would like to say something?
Thank you, Dr. Clark. And
I gotta go. Goodbye, everybody.
Goodbye.
Thank you.
Thank you so much.